Okay, we'll get started here. Uh, so it's around 2:05 or so. I'm sure we'll have people continue to trickle in. Uh, so today's webinar is how to read a lumbar MRI for regenerative medicine. And this is on behalf of the Interventional Orthopedics Foundation. My name is Chris Centeno. I'm one of the board members of the foundation. And also been very involved in this type of work for quite some time. And I'll go into that just a little bit here. I'm going to silence my phone, sorry about that. So we'll start with what I call some unabashed nonprofit commercials. So the sponsor of this talk today is IOF, Interventional Orthopedics Foundation. It's a 501c3 that's dedicated to interventional orthopedics, which is non-surgical orthopedics, the focus being trying to regenerate tissue via injection and guided injection. And we're really looking at IOF to create a new medical specialty that bridges the gap between conservative orthopedic care and invasive surgeries. Really analogous to interventional cardiology. So interventional cardiology, as you know, currently dominates cardiovascular care, but that wasn't always the case. In the 1980s, when I was in residency, it was quite the opposite. The surgeons dominated cardiovascular care. And we really need your help to build and shape this nonprofit. This is not a one-man job. We have other board members who are very, very involved, and we want to continue to grow this organization. So if you're interested, go to interventionalorthopedics.org. And we'd like you to join IOF. You get discounts on our educational courses. You can view webcasts of the annual meeting, education sessions, such as a bone marrow course. You get a complimentary listing in the directory of members, opportunity to serve on IOF committees, and other benefits like being able to participate in the registry database, which is really the largest on earth right now. Also, consider the conference. It's coming up here in February in Colorado, and it's really going to be a very interesting conference. It's the only regenerative orthopedics focused conference that's interventional orthopedics that really is a nonprofit. Everything else in this area is either a for-profit or focused primarily in other directions. We have a BMA lipo course. Obviously, you can ski. It's tax deductible. We have a great session on how we deal with the regulatory challenges that are coming our way, etc. And there's a core skills program. So what I mean by that is that unlike other organizations where you go take these little weekend courses and they kind of teach you whatever it is they teach you, IOF believes very much like SIS does in spine, that regenerative medicine is a field that requires advanced training. So we start in level 1 with every body part, then we go to level 2, and then we go to level 3. In level 1, it's simple intra-articular injections. In level 2, it's specific structures. In level 3, it's advanced structures plus bone. And so, for instance, we're teaching a bone aug level 3 course in the hip and knee coming up at the conference. So why give this lecture? I see a lot of physicians practicing regen med who depend on the radiologist report and really never ever read an MRI themselves. And I think they're really missing out. They're really not doing the best possible by their patients. And the problem with the report is we have surgery and then we have conservative care. Now there's this other thing in between these two extremes that you and I are out there trying to perfect. But regrettably, the report only focuses more either on whether this is a surgical issue or a conservative issue. And in fact, radiologists are people, and they're influenced by their referral sources. So they don't comment on a lot of things they probably should, simply because their referral sources are usually surgeons, and they're usually not interested in knowing those things. So you really need to be reading all of your own MRI films. Very, very important, because there's, as I'll show you today, there are things on those films that you're not going to get in a report, but that will help you plan a good regenerative medicine treatment for that patient. And again, I'm not trying to focus here or train you to be a radiologist. My goal is to just point out some things that you should be looking at that might help really guide your treatment. Now, one of the first things I'd recommend is to get a single DICOM viewer. I use Radiant off to the right there. I've got no connection with that company at all. It reads everything really well. And it also allows me to master the feature of one DICOM reader without having to learn 30 or 40. As you know, I mean, you get an MRI CD from a patient, and it could be one of 20 or 30 different programs, and there's no reason for you to do that. That's not the way the radiologists do it. They'll use a single DICOM viewer that they get comfortable with. So this one is really a nice one. There may be others on the market, but we found this a couple years ago, and we've never looked back. It's awesome. Also, have a large monitor in every single patient room. We use 27 or 28-inch monitors just so that we can make sure that that bonding with the patient occurs. Here's your film. Here's what's on your film. Here's what I think about it. It's a critical step in patient care. So before we get started into all of this, you need to take MRI findings with a grain of salt. And what I mean by take them with a grain of salt is that, regrettably, there are many studies, almost too numerous to list, which is the reason why I didn't list them here, that state that some MRI findings could be related to pain. Most MRI findings aren't necessarily related to pain. So you've got to be able to do an excellent hands-on physical exam that lasts more than 5 minutes, and really delve into, does this picture correlate with what I'm seeing clinically? So let's just go over some MRI basics. As you know, there are 3 planes that we'll look at today: sagittal, coronal, and axial. And that's what those look like on an MRI. Axial image off to the left, sagittal in the middle, coronal off to the right. And very, very important for you to understand that the patient is lying supine with their feet coming out of the screen towards you and their head on the other side of the screen. So that right is actually backwards. That's the right on the patient, and that's the left on the patient. So very, very important that you understand that those are backwards from what you would normally assume. So different types of weighting for sequences. There's a T1 sequence which shows fat as bright. There's a T2 which shows water as bright and bone as dark. There's a subset of T2 sequences called STIR or IR, which is short tau inversion recovery. And all they are is they make water even brighter. They're also sometimes called fat sat sequences. And then there's a proton density image where if something has more protons, it's bright. So if we look at this image, we can see that water is bright here. So the water in the cerebrospinal fluid around the cord. We know that bone is bright. And so we can see here water is bright, muscle is dark, fat is bright, bone is bright. This is a T2 FSE fast spin echo. So fast relaxation, fast spin echo type image. And that type of image is very, very commonly seen in lumbar MRI. Now let's look at this. We have a STIR or IR or a fat sat, We have water is even brighter. Fat is dark here, and muscle is dark. So another very, very common image that you see in lumbar MRI. Here we have a T1 image where you have bone is bright, fat is bright, muscle is dark. So we have those different sequences. Now let's kind of look at what's where, just some normal anatomy. So in the axial image, we have an exiting nerve root there, a foramen there, a central canal with the dura and descending nerve roots. The nerve roots are those little dots. We have a spinous process, an ilium here because we're low down at L5S1, a multifidus muscle, which is the deepest layer there, a thoracodorsal fascia, facet joint, vertebra, psoas, and the supraspinous interspinous ligament complex connecting into the thoracodorsal fascia. On the sagittal, we have a foramen, a nerve root, multifidus, facet, nervovertebral disc, pars interarticularis, the part between their articulations, vertebra. So now let's talk a little bit about disc hydration. With regard to disc hydration, this is a key component of modern lumbar MRI. So you've got good hydration on a T2 weighted sequence. Either this is a STIR image, but it also could be an FRSE or FRFSE. And you've got poor hydration. The good hydration you see as bright in the disc. The poor hydration of the disc you see as dark. And then everything in between. So what's happening? You're getting loss of nucleus pulposus cells or injury that produce these gags. So there are cells inside the disc that produce gags. The loss of gags from the dead cells is a problem because gags hold on to water, so you have less hydration. The disc turns dark on T2. And you also lose viscoelasticity or shock absorption. So what is viscoelasticity? Silly putty is viscoelastic. You take silly putty and you put a book on it and you walk away for a half hour, you come back, it flattens out. So long static loads tend to flatten it. Whereas if you throw silly putty against the wall, it bounces like rubber. So it's both viscous and elastic. And the disc is identical. So basic skills. Where do the nerve roots come out? A very important thing to understand because you're going to be responsible for saying this disc is probably affecting that nerve and that's what I should look at or look for on my exam. So the spinal nerve exits at the first name level for the foramen. For example, at L5S1, it's where the L5 nerve exits. So for a central L4-5 disc, however, recognize that can impact the descending root. So what I mean by that is a central L4-5 disc can impact the descending L5 nerve. Very important concept. So I'm going to just grab a pen here and draw on the screen. So at L5S1 at this level here, we see the L5 nerve root comes out at L5S1. But recognize that the L5 nerve root comes up centrally this way, so that a central L4-5 disc can cause problems in the L5 nerve root. So if we're looking for lesions, we look at, and we saw a patient with an L5 problem, it would be either a central disc at L4-5 or a disc in this area could also cause problems at L5S1 further out laterally. So this is a little thing I put together that I call Follow That Nerve, and it just goes over with you how all of this works so that you can get a sense of how to follow a nerve on an image. So I'm gonna play this here. Okay, let's play Follow the Nerve here. Critical skill for looking at MRIs. So we're going to look at an axial and a sagittal. This line will tell you where we are. And we're going to start at the very bottom and work up. So we see here the left and then the right S1 nerves. So again, S1 nerve here, S1 nerve there. And as we come up, those S1 nerves, you can see them here and here, are going to move towards the center, and they're going to disappear into the dura. And then we're going to start to look out here for the L5 nerves. And so now we're at the L5-S1 foramen, and we start to see an L5 nerve there, and we're catching an L5 nerve there. And then you can see an L5 nerve here and an L5 nerve there. So now we're at the top of the L5-S1 foramen. And again, these L5 nerves then are going to go inside. They're here and here. We're going to get into the subarticular stenosis area, the area here that is right behind, if you will, or anterior to, I guess you could say right in front of the facet, where you can have nerve impingement. And now we're going to continue up, and eventually we're going to see an L4 nerve here. So L4 nerve, right there and there. L4 nerve, L4 nerve, so we're at the L4-5 space now. L4 nerve, L4 nerve, L4 nerve, L4 nerve, and that's going to join in, and then eventually we're going to pick up the L3 nerve at the L3-4, L3, L3, L3 nerve, L3 nerve, L3 nerve joining in, and eventually it joins in to the dural sac here. So you get the idea. Okay, so you got the idea there of what was going on and how to follow the nerves from the bottom up. So now that we have some sense of how to find the nerves and where they are at any given slice, axial slice, now let's talk a little bit about disc bulges and herniations, protrusions and extrusions. So disc bulge and herniation types. There's a diffuse disc bulge, and I'm going to actually, again, get a pen here. So we have a diffuse disc bulge, which kind of goes out slightly in all directions. Then we have a broad-base disc bulge, which tends to go a little bit more in one direction, usually posteriorly. And then we've got a focal disc protrusion, and then a disc extrusion or herniated disc. And the actual definition of this is that this length gets to be more than that length. So basically the anterior-posterior length gets to be more than the medial-lateral length, and it's officially a herniated or extruded disc. And then there's a sequestered disc, where a piece of the disc material goes into the canal. And then, obviously, you can name all of these based on where they are. So you've got a central disc, a paramedian disc, a foraminal disc, or a extraforaminal disc. And this just discusses the difference between an annular tear, where there's disc material that's actually visible in the annulus, versus an extruded or disc here. And there's more scattered nomenclature. However, from a regen med standpoint, it's more how do you help these patients? What do you do for these patients? Now, for disc bulge or HMP, we use platelet lysate. So what does that mean? Platelet lysate, you know, you might be familiar obviously with platelet-rich plasma, but you may not know what a lysate is. So basically, a lysate is where we take the growth factors out of platelets, versus platelet-rich plasma has the growth factors still contained in a platelet. And there's really been a lot of discussion about intradiscal PRP, And one of the confounders in some of the research and some of the clinical experience with injecting PRP into the disc is that basically what we're going to see is if we put PRP in a disc, we're going to see the individual platelets degranulate their stuff over time, which can lead to growth factors leaking out of the disc into the epidural space. So one of the problems with an intradiscal response is that we may really just be seeing an invasive epidural response. And we keep patients safe by offering the least invasive therapy that will address their condition and problem. Also important to note that no PRP or bone marrow concentrate study to date has shown remission of a disc bulge. And we know this well. We were the first to inject low back discs with bone marrow concentrate in approximately 2006. In our experience, only specially culture expanded MSCs injected into the annulus can reduce disc bulge size. And that's something we have an upcoming paper in review on that hopefully should get published this year. So we're going to walk away now from discs a little bit and get into multifidus atrophy. So multifidus atrophy is probably the most significant MRI finding that is absolutely positively ignored by 99.9% of all radiologists. What is the multifidus? Well, the multifidus is this deep spinal muscle in here, or it would look like this if we were looking on the coronal, that helps to provide segment-to-segment stability. So it's a key stabilizer of the lumbar spine. And this is actually from a paper, an early paper by Kader, K-A-D-E-R, where he actually proposed a grading scale. So you can see here a more mild atrophy where you have dropout of this area, and you can see some fat atrophy in there. And then you've got moderate where you start to see the more fat atrophy within the multifidus. And by the time you get to severe, you have complete dropout or mostly complete dropout of the multifidus. Now, many of the patients we see are even beyond severe. And in fact, one of the things I think that Kader did wrong here in his early paper is that he's got a lot of atrophy in the paraspinals here as well, rather than just selective atrophy of the multifidus in this compartment that I'm striping here. So just recognize that you'll see a lot of patients that are actually more severe, have more muscle dropout than Kader's severe. And one of the problems with Kader's pictures here is that some of this paraspinal atrophy here has now been shown to just be related to disuse, whereas the multifidus specific compartment is more related to nerve irritation on a segmental basis. And God, there's a ton of research on this. I went back and preparing for this lecture just to look at what was going on more recently in the last year or so, because I hadn't looked at it in about a year in multifidus atrophy, and it's all the same stuff. I mean, multifidus atrophy is associated with low back pain, lake symptoms, and radiculopathy. Again, huge finding, tons of research, absolutely absurd that this is not read out by every single lumbar radiologist or radiologist reading a lumbar spine film, because it's clinically important. It's actually more clinically important than some of the things they're reading out. So can we treat multifidus atrophy with PRP? There's only one study that we're actually going to try to replicate. I met with some of our fellows this morning about starting to plan this study, and it was published recently in just this last March, and it did show that serial leukocyte rich PRP seemed to cause MRI improvement of multifidus atrophy and improved pain. One of the things I've seen talked about on the Biological Orthopedic Society and LinkedIn is that we really don't have a these MRIs that they put in their paper look like they're a little bit off on the comparison. So it looks like this one's at slightly different, a slightly different level than that one. So something to consider, and it's one of the reasons why we're going to redo this study. But if this is actually true, if this holds up, this is a major treatment. It's an important treatment. Multifidus atrophy, we know, causes instability. We know it's linked to pain. We know it's linked to radiculopathy. We know it's linked to recurrent low back pain. So if this can actually hold up, this could be a major treatment of back pain and really should be factored into lots of regenerative treatments. Now let's talk about disc tears and discogenic pain, or HIZs, high intensity zones. High intensity zones are these white things that you see in the back of the disc. They look like that, or they'll be little tiny pieces like this. And what this little tiny dot here is, you can see, is actually this more circumferential bright spot there. So that's what a high intensity zone, or HIZ, looks like. So HIZ. Now, very, very important finding, or is this just something that happens as we age? Well, we know that when we look at some of the more recent papers on this, there was a time many years ago, maybe 10, 15 years ago, where it was HIZs. These are important. These are associated with discogenic pain. And then there was a lull in the literature about 5 years ago where some people started to come back and say, well, no, they're also found in asymptomatic controls. And it seems like the more recent literature is associating this brighter HIZ with discogenic pain. So the really bright ones seem to be the ones that are associated with discogenic pain versus the ones that are not as bright. Now the problem is, what is bright? That's a hard thing to quantify. But you know, if you do a lot of discography, again, you can take your MRI images and start to correlate them with your discogram results. Now, interesting that we have a couple studies in this regard. Greg Lutz's study, and Greg will actually be at the IOF conference, but Greg Lutz's study came in and used leukocyte-rich PRP, and it helped pain and function. And what was interesting is it seemed to work better in patients with good disc height. So this is intradiscal PRP, or HIZ, or positive disco. So basically, these were classic discogenic pain patients. And if you haven't looked at the discogenic pain literature, it's important to note that a classic patient is someone who's younger, let's say 50s or younger, someone who has good disc height, and someone who can't sit, and or has a positive HIZ that's bright on an MRI, and or a positive discogram. But those are the patients that did best with intradiscal therapy. We also have another paper by Patine that was published a while back, and then there was recently a two-year look at these patients. This is a case series, not a randomized controlled trial like the first one. And one of the problems with the study is they didn't use discography in everyone. So it's a little difficult to tell. I'm assuming, just looking at the data in the paper, that most of these patients, again, were presumed to be intradiscal or discogenic pain, but bone marrow concentrate worked very well in this population, although they didn't talk specifically about HIZs here. They did show a very mild improvement in the appearance of the disc, but the problem is it was only 1 grade higher in the scale they were using, which had 8 grades to it. And that was within the margin of error of the grading system. Stenosis. So what does all this look like? So we've got here a couple different kinds of stenosis. The two biggest things you'll see are central canal stenosis. That's obviously when the central canal itself here gets smaller, so you can have pressure coming in from the ligamentum flavum, pressure coming in from the facet joints, and pressure coming in from the disc. Lateral stenosis is more bone growth within the foramen or from the facet, or a posterior lateral disc bulge causing stenosis. This can also be called lateral recess stenosis out here and foraminal stenosis out there. So if we just stick with the simple definition, central canal stenosis, one of the things that you see is a hypertrophied ligamentum flavum. So ligamentum flavum here I am outlining so you know where it is. It means the yellow ligament. So a couple things. One of the things that you may not know is ligamentum flavum is actually tied into the interspinous ligament, which ties into the supraspinous ligament. So interesting that all of this stuff is connected. Now, this ligamentum flavum that I just outlined here is very, very thick. It's actually about 3 times thicker than it normally is. And so that causes central canal stenosis. You can get facet hypertrophy pressing this way. But there's only a little bit of that here. But there is a broad-based disc bulge here that causes a problem there. So you tend to get something that goes from a circle to a triangle, or trifoil stenosis. Lateral or foraminal stenosis, usually due to, again, facet hypertrophy and a disc causing some focal decrease in the hole or the foramen where the nerve exits. So now let's talk about symmetry. We've focused in on some specific things. Now let's go big picture for a moment and talk about symmetry. So we have lordosis and kyphosis, as well as scoliosis. On the lordosis kyphosis side, incredibly important, yet often underdiagnosed. We have studies that show that lack of lordosis may be related to pain. It's certainly going to impact a lot of things. So if you've got lack of lordosis, one of the things you have is an awful lot of pressure on the disc. In addition, one of the other things that you have is that the center of gravity changes. So now the center of gravity moves forward in this patient so that their head is now an incredible weight that's not balanced over the spine. And chiropractic biophysics, that's at idealspine.com. Again, I don't have any relationship to these guys. I just like what they do. Has produced peer-reviewed literature that shows that increasing curve reduces symptoms. So interesting, and I've sent many patients through the years to try to get their curves restored using this technique. And we're also now starting to see spinal surgeons who are recognizing that if you're going to fuse something, you would better fuse it into a normal lordotic curve where that causes other problems. Scoliosis is obviously the side bent curve. And you may need to look at the scout coronal image because coronal images don't come standard on MRIs. And one of the things to consider is that the facet joints on the concavity are going to get overloaded. So you might want to look at the facet joints on the concavity side. And the ligaments on the other side are obviously going to get stretched. So those are things to consider. And we've actually begun to perform percutaneous scolioplasty with autologous biologics to resist further collapse of the spine. And so far it's been pretty successful. We've just started doing this in the last year. Actually, it was one of my assistants who had some issues that needed to be treated, and she's actually done quite well, much to my surprise, because she's got severe scoliosis. In fact, this is her image off to the right there, and you can see she's got fairly severe scoliosis. Again, something to consider is that you may have to look at the scout image in order to be able to see the lumbar spine and coronal. But recognize the side of the concavity is where you get facet overload, and on the other side you've got ligaments and muscles that are stretched. So on the facet overloaded side, obviously you may want to consider treating those facets with biologics. Spondylolysis and listhesis. So this is a simple issue of high signal in the pars interarticularis. Again, we see the pars here. We can see this high signal. Certainly when you compare it to this one, there's a big difference. High signal within the pars interarticularis. And on this axial image, you can actually see breaks within the pars, here and here. These are the facets back in this region, but those are breaks within the pars. Now, MRI is not the best way to evaluate this, so a CT scan might be a better way to evaluate it. And then you can actually have listhesis, and that listhesis can go forward or backwards. So if it tends to go forward, it's called an anterolisthesis. Antero. And if it goes backwards, it's called a retrolisthesis. And obviously this is graded, grade 1, grade 2, grade 3, grade 4. And what's interesting here is, again, you need to recognize, and I'll talk about this later, you've got the supraspinous and interspinous ligaments connecting into the ligamentum flavum here, so you do have a support structure that you may be able to strengthen, and that's actually one of the courses that we'll teach through IOF. So here's a spinal listhesis grade 1. You can see here, if we line up this versus that there's a step off, and you actually see the disc kind of coming up like this, and that's called disc uncovering. Now, we've treated spondylolysis in a young man with HDBMC. HDBMC is high-dose BMC. It's not generally something that a machine can produce. It has to be produced in a lab because we get the levels much, much higher than you can get with a machine. But we used that plus demilitarized bone matrix and excoriated this thing with a 15-gauge trocar, and you can see a pretty big difference here in just 3 months. Eventually, this was read out as completely healed by the reading radiologist. Facet arthropathy. So you can have a facet effusion, which is, if you look at this facet, you don't see any bright signal on the T2 weighted image inside the joint. But if you look at this facet, you can see this bright signal inside the joint. And that's a mild facet effusion. You can get facet hypertrophy. The facet can get all sorts of weird shapes and, again, begin to crowd out the foramen, which you can see it's doing here. And we, like others, have seen excellent results with high-dose PRP. We tend to use 14 to 20x injected into the lumbar facets. This is a recent paper showing that PRP was superior to corticosteroid in producing longer duration pain relief. So interesting research that's being done that's consistent with what we've seen for many years now. Facet cysts. Obviously, the facet can, like any joint, get cysts. You can see here a synovial facet cyst here, and that cyst is putting pressure on either the exiting or descending nerves. Here, the cyst is big enough where it's changing the shape of the dura, which is over here, and pushing the dura that way. On the sagittal, the facet cysts tend to look like these little circles or half circles within the spinal canal. Now, we've had good success with bursting these and then treating with PRP or BMC. Mostly PRP. This is actually a corticosteroid study that showed that if you did this, 55% of the patients never had surgery at 4-year follow-up, which is pretty good. I mean, you just scratch your head and wonder why anyone would get surgery for this condition when we know that if you just burst it, there's a pretty big chance you're not going to get surgery at 4 years. But many of these patients will be offered surgery without bursting this. In fact, the radiologist just, or not the radiologist, but the surgeons just produced a nutty study that seems to say it's far better to get surgery out of the gate than get an injection that obviously doesn't consider that getting this injection is far safer than any surgery. And you do see this type of crazy large contrast spread when you actually go ahead and burst one of these. Sometimes they won't burst. They can be loculated in the more complex patients, but it's certainly worth a try at bursting them rather than a surgical procedure where you're going to destroy the multifidus just getting to this thing. Modic changes. So we've got Motic type 1, 2, and 3. You can see here, this gives you a visual guide of what these motic changes are. You can see Motic 1, which is a little bit dark on a T1 image, and then bright on T2. Motic 2, where they're both bright on T1 and T2. And then Motic 3s, where you've got a dark signal on T1 and a darker signal on T2. Some things to note: Motic 1 is most associated with pain, and Motic 2 is associated with inflammatory cytokines in the disc. So again, motic changes are these changes in the bone around the intervertebral disc. And there is a huge controversy right now as to whether motic changes represent a disc infection. So the presence of bacteria in discs with motic changes in various studies is reported pretty wildly, from 3 to 53%. So a very, very large swing there. And there's really no consensus on whether this represents a disc infection. But having said that, given that PRP and BMC are antibiotic per the recent research, you have to wonder whether or not this is a very good place for intradiscal or even intervertebral autologous biologics. Tarlov cysts. Most common area is in the sacrum, and for many years these have been considered asymptomatic, and now there's more of a push in the literature that in some patients where they're larger, they may well be symptomatic. Something to consider is that there's at least 2 studies, this is just one of the ones I found, that showed that draining these things and putting in fibrin glue seems to be effective. Now you can see here they're using a trocar to drain this thing, which I think is way overkill. I think you can drain this thing obviously with a 22 gauge needle. This is an 11 gauge. There's no reason really to use an 11 gauge here. I think you're just taking additional risk. But basically, as you can see, it's injection of contrast in the Tarlov cyst, then drainage, then they'll put in some fibrin glue. But again, why not do this with platelet-rich plasma, which is going to coagulate, or PRP that you coagulate, rather than fibrin glue. Surgical changes. So discectomy and laminectomy. So you can see here what a level looks like after discectomy, mostly collapsed. And then after a laminectomy, this is the lamina, this is the facet, this is the spinous process here, and you can see here that the lamina is missing. Now, in addition, you can see they've also taken out a portion of the medial facet joint, which can cause instability. Here you can see outright surgical damage. You can see the surgical damage in the subcutaneous fat, and you can see here the thoracodorsal fascia, which is bumped out from the surgical approach in a patient that had multiple discectomies and laminectomies performed. Fascia, let's take a look at this fascia. So I'm going to actually show you this particular patient, and I screwed that up, sorry guys. We'll have to blind that out in the final video. But you can see here very, very clearly that you have a patient who, as I just showed you, has a bump out of the thoracodorsal fascia. And what we should be seeing here is the thoracodorsal fascia should attach like this to the spinous process here and the interspinous ligament. But in fact, you can see the thoracodorsal fascia has pulled off of the spinous process. And you just have to wonder in this patient what in the world is happening here, where you've got a scenario where a major anchor point for the thoracodorsal fascia is lost. So let's look at some contrast images, meaning radiographic or MRI contrast. Perineal fibrosis or nerve root clumping or nerve root scarring. You can see here an image of, rather than being distributed equally, where the nerve roots have actually clumped in one direction, which is one way to look for this. So this is usually post-surgical scarring around the descending or exiting nerves. Here you can actually see gadolinium enhancement. So this is the unenhanced one, and this is the enhanced one. And you can actually see enhancement of the posterior disc and the entire area around the nerve, indicating scarring. So you'll see enhancement on T1 with gadolinium around where the nerve should live. We know here that this is the left nerve, and we can actually, I'm sorry, that's the right nerve. We can actually see the left nerve right here, but it's surrounded by this enhancement, which is scarring. And then we'll end this up with ligaments before we start to read some things. As far as ligaments are concerned, we've got the ligament of flavum inside here that I discussed, which is connected into the interspinous ligament, which connects to the supraspinous ligament that goes over the spinous processes. We've got intertransverse ligaments, and we've got an iliolumbar ligament complex, which goes to the pelvis. That's the inferior band. There's also a lateral band that comes out this way, and even a superior band that goes up to the neck's transverse process. And recognize that the iliolumbar ligament is confluent with the ligaments at the front of the SI joint. So if we look at what we can see on these images, you can see the interspinous ligament clearly and the supraspinous ligament. As far as the iliolumbar ligament, you can often see that on axial, and you'll see that right here coming off of the spinous process there. And this is just from one of the ligament courses at IOF, where you can learn how to inject these ligaments. This is actually the lateral band of the iliolumbar ligament, and this is called the intertransverse or the superior band of the iliolumbar ligament. There's also an inferior band that comes down this way. Schmorl's nodes. Schmorl's nodes are these holes in the end plate that look like this, and they're not as common in the lumbar spine as they are in the thoracic spine. But interestingly, there is some research showing that they may be related to pain. So for many, many years, they were considered to be not a pain generator. And just to let you know, at the IOF Core Skills Program, we actually have an intradiscal course that should be coming up in June, and then sometime this year we'll do a level 1 spine ligament course under fluoroscopy and under ultrasound. So those courses are coming up in the Core Skills Program at IOF. Okay, so now let's read some MRI images. So how I had to do this to try to shield you from the patient names is actually had to go ahead and record these yesterday. So I'm going to start this, and it's going to go through a basic read. We'll do 5 of these. One that goes through just a basic read, and then 4 specific instances and cases. But this is, more to how to navigate. So I'm going to start this and let this run for a couple minutes. I'm going to take a little break, and I will be right back as you watch this. Okay, let's take a look at our first MRI here. This is the axial sagittal. One of the first things that jumps out in the sagittal is that nice disc bulge here, decreased disc height as well as decreased signal intensity of the disc. Now, if we move the axial down to that level, we're going to see a laminectomy defect here. You can see there's a little bit of a laminectomy defect on the other side as well, but a large one here on the right with a facetectomy, meaning that they've taken out a good portion of the facet, which causes instability. You can also see quite a bit of difference between the muscle compartment here on the left. You can see that there's no multifidus here, but at least there's some longissimus and other muscles, whereas on the right, where this large laminectomy has occurred, there's really very few or very little in the way of musculature, which is interesting because
we now have a 1-2 punch of stability issues here. We've got a portion of the facet removed, plus they've destroyed the musculature with the surgery. So if you look here on this sagittal, you can notice some other strange things going on back here. So basically, you can see the supraspinous interspinous ligament here normal, normally dark. There's a little bit of decreased signal here in the interspinous ligament higher up, but down here it looks like a bomb went off. This is surgical injury here, and what's really fascinating is that we notice something back here that doesn't look so great. So let me cue that up here. So if we go higher up, we see a more normal spinous process, thoracodorsal fascia, and the supraspinous interspinous ligament that are all connected here and anchoring at the spinous process. As we come down, all of those structures peel off of the supraspinous ligament, which is right here, and there's actually a break between the two and separation between the thoracodorsal fascia and the supraspinous ligament and spinous process, which obviously is causing severe biomechanical difficulties here because there's no anchor anymore on the spinous process for the thoracodorsal fascia. So lots of issues going on there. We go further down, we can see the S1 nerves right here. We can see the exiting L5 nerves up in here. And we can also see an issue with fluid in the opposite facet joint here, this bright signal on the left. Now, what's interesting about that bright signal on the left is that you've got instability at this level. There's not much left of the right facet joint, so it makes sense that the left facet joint would be chronically overloaded. You can also see here a hemangioma higher up. And if we go and look at the sagittals here, you can see some decreased disc height. You can see disc material in the foramen, and then you can see the exiting nerve, exiting nerve, exiting nerve. So the exiting L5 nerve abuts or comes close to that exiting material, so we might want to look for an L5 radiculopathy in this patient. And, if we go further up to the L4-5 level, we see a little bit of facet hypertrophy, and we see just a little bit of foraminal narrowing here, but not much. So let's go on now to the next MRI. Okay, now let's read another MRI here. We can see here on the sagittal on the left, and then on the axial on the right. On the sagittal here on the left, one of the things that we note is that there is a significant step off here, a grade 1 spondylolisthesis relative to the sacrum, and obviously a degenerated disc with decreased hydration as well as disc height. There's also what's called some uncovering of the disc, which is where you get this disc bulge on the lip here, which is going to look very, very interesting here on the axial. It tends to look like this long, dark line, which is what's called uncovering of the L5S1 disc. We can see some multifidus atrophy here, worse on the right than on the left. We can see the SI joints there, ilium, etc. If we're looking at the nerve roots, we can see the descending S1 nerve roots here and here, here and there, then there and there. Now, interesting enough, we do see some signal change in the bottom part of the L5S1 facets, which may or may not be clinically important. We see the L5 nerve here, harder to see on that side. And then as we go up, we tend to see this more diffuse muscle atrophy, not just in the multifidus, which I think is important to note. It's very common in middle-aged and older patients, especially patients that tend to be not as active. Then as we go way up here, so 5-1, 4-5, 3-4, 2-3 to the 1-2 level, we see decreased disc height, and we see a slight bulge here with bone spurs out to the front, and then out in the back there as well, a slight bulge, which is harder to see here because of this writing they've got here on this particular MRI. We can also see some end plate violation or end plate fractures here, or Schmorl's nodes. There's one here, there's one here, and there's one there. And we can see a slight retrolisthesis of L1 on L2. And here we have a anterolisthesis of L5 on S1. So those are the main things in this particular MRI. Okay, another MRI here. This one a little different. This patient actually received an L5S1 culture expanded intraannular stem cell injection, which got rid of a huge bulge with HNP that he'd had that was persistent. And this is actually a post-op film because I'm trying to illustrate different things here. But one of the things we can see as we delve into this is he's got a small HIZ here, high intensity zone, at the back of the L5S1 disc, and then a larger HIZ at the back of the L4-5 disc. Now, what's interesting about this particular segment is that despite having decreased disc height here, he's actually got reasonably good hydration, which is unusual and may be an effect of the stem cell treatment. You can see some post-surgical changes here, and you would think that this was a disc herniation that is migrating inferiorly underneath the posterior longitudinal ligament, which is right here. But in fact, that's not really the case, because when we look at that area on the T1, we don't see that. So this is different than the disc that we're seeing here. And again, this could be a function of the stem cell treatment that he had had previously. Now, what's interesting here is he does have some motor changes, which are type 1, bright on T2, slightly dark on T1. So those are associated with pain, so important to note. If we move on now to the axial on this patient, as we come down here, we can see that there is this bright area here in this portion of the disc that shows up as dark here. If we track that relative to his S1 nerve roots, though, here and here, they're not really abutting. We're not seeing any change in shape of those S1 roots or change in position. So not as big a deal. We can see the L5 roots there. But we can see now better his annular tear, or HIZ, at L4-5. We can see its actual true morphology here is more circumferential than radial. So interesting here, it's very bright, so this would be one that is probably associated with some disc pain at 4-5. You can see that this one is not quite as bright, probably less likely to be associated with disc pain. Now again, what's interesting here is we go down to the 5-1 facets, we see a little bit of fluid in the facets, but we go up now to his 4-5 facets, and we're seeing quite a bit of more fluid in the 4-5 facets. If we check that out against the facets up top at 3-4, again, the 4-5 seem to have more fluid, so that, again, might be something to consider. He has a small focal central disc bulge right here at L4-5, and it's possible that that could impact the descending 5 roots, which are buried in here. So that's something to consider. Okay, one last image here. You can see that we have the axial T2 and the sagittal T2. If I go all the way down to the bottom, we're going to see a fairly large focal, central and paramedian, more off to the right than the left, disc bulge, almost approaching a herniation. We can see that the S1 nerve is here and the S1 nerve is here. There's some thickening of the ligamentum flavum back there. And you can certainly see that where this nerve root should be, as I go below and then come above, it's a bit obliterated. So the right S1 nerve is likely the one getting impacted here, and certainly the one that you would look for clinically. And then as we come up towards the L4-5 level, you see a change in shape of the spinal canal. So this is mild central canal stenosis. You can see ligamentum flavum hypertrophy here, meaning the ligamentum flavum is larger. It's this dark line right here, and it should be really a third of that thickness. So we're starting to crowd out the central canal, likely due to degenerative instability, and not too surprising that we're seeing a little bit of fluid in the facet at L4-5 on the right, and in general, some change in shape of the foramen. Now, to really appreciate the foramen, we're going to go to the sagittal and see that, you know, the nerve root's up here. So let's make this bigger here. So L4-5, the nerve root's up here. Certainly this foramen is a little bit more closed off than this one at L3-4. So possibly an L4 nerve issue could be in play there. And just going to scan through the rest of this image. Now, there is a small facet cyst here, much higher up. If we look at the level there, 5-1, 4-5, 3-4. So that's more at the 2-3 area. So there's a small facet cyst here, a very tiny one there at the L2-3 facets. And as far as multifidus is concerned, we've got just a little bit of atrophy here at L5S1, but not as severe as you might think it could be. But again, if we looked at that before, that disc bulge, which is right there, it could be affecting bilateral S1 roots because you don't see muscle dropout only on that right side. So that's really most of what's on this particular MRI.
Okay, we're going to start taking some questions here in just a minute. I just need to move my camera again. Had to move it just to make sure that you guys could hear better. Okay, so just moving on here. Again, going to mention the IOF conference. Definitely should be a really good one this year. So we'll send you an invitation after this so that you can get signed up for that. So let's go on to questions. I'm going to open up my question box here and start to take some questions. So what do you make of discs that have normal height, no HIZ, no herniation, but moderate degree of water loss on T2 weighted images? Confirmatory discs, disco prior to your disco procedures. Yeah, John, it's a good question. I'm not a huge fan of discography. I've certainly done hundreds through the years, but I don't necessarily use it as a first line diagnostic tool because of the potential damage that you can do to the disc. So if that patient was looking like a disc issue, i.e. they had substantial issues tolerating any sitting, and they were younger, and I had tried extradiscal treatments first. And again, I think it's really important to bring up that at the end of the day, we shouldn't be just sticking discs just because. A discography in my book is only ever appropriate after extradiscal treatments have failed. So you've tried biologics in the epidural space and they didn't work. So you're moving on to this, or you've ruled out other pain generators, etc. Alariza, what is the preferred lumbar MRI protocol in respect to slice thickness gap and axial sagittal planes, 2 millimeters, to accurately evaluate discs and all these other things? Yeah, Alariza, normally these are 3 millimeter slices. It's certainly possible to get them thinner. One of the problems with getting them thinner is, I think, more practical and more financial on the base of the part of the imaging center. So could you see more detail? For instance, if you had 1 millimeter slices, you could, although you may have a hard time convincing an imaging center to do 1 millimeter slices based on the time. So normally these are 3 millimeter slices. Why do you use leukocyte? I think you mean leukocyte poor, maybe, PRP. It says LPRP, but I think it should be LPPRP. Into the facet joints, and why is the concentration of 14 to 20x? Zhao. Yeah, Zhao, we've looked at the different types of PRP, the two main different types, leukocyte rich and leukocyte poor, with regard to their ability to stimulate mesenchymal stem cells, the kind that you would find in a joint. And leukocyte poor did much better than leukocyte rich. So the amber PRP did better than the red PRP. Then there's a stair-step response in older patients with regard to concentration. So if you expose an older patient to 10x, they do better than, or their stem cells do better in vitro than 5x. Or if you expose them to 15x, they do better than 10x. So that's why we go much higher. Now, these things aren't commercially available. You can't just go buy a little automated bedside centrifuge and have that happen. You've really got to do this stuff in the lab if you want to get that kind of concentration. Let's see. Rob, can you describe and or show how to easily tell right from left on the sagittal images? Yeah, Rob, again, I think as I said early on in the talk, the patient's feet are coming out, and on the axial image, it's backwards. Now, on the sagittal images, I wish I could just open up a viewer here. My concern with opening up a viewer is I'm going to show you a patient name, but the bottom line is the way to do it is just to have two windows open. So first is I'd get that Radiant software that I talked about earlier in the talk, because that's a good one. You can easily put two windows up. So you have a axial and a sagittal. And on that software, it's very easy to see where you are, because on the one image you're seeing the slice, and then the other image, or seeing where the slice is, and the other image you're seeing the slice itself. So on the sagittal, as you march it left or right, you can see it going left or right on the axial. So that's the easiest way to do it from a practical standpoint of determining where you are. Now, many times, most of these things are set up left to right as well, low to high. But if you just open up two windows, you should be able to tell the difference pretty easily. Dinesh, can you elaborate on intravertebral BMC injection for modic changes? What's going on with bone marrow there where more BMC would make a difference? Yeah, I don't think more BMC, Dinesh, but what we're talking about is high-dose BMC. So, for instance, in the Patine study, what they found was that the highest CFU content, meaning the highest mesenchymal stem cell content patients, did the best. Now, they had maybe 60% of their patients that responded well, and they were all in the higher dose group. So one of the problems with using a little bedside machine is that, let's say if you take 60 cc's from a patient, you throw it in the little bedside machine and it gives you 10. Now, that's not the size of the stem cell fraction in there. The actual size of the stem cell fraction is about 1.5 cc's out of 60. So you're getting 1.5 cc's of stem cells and 8.5 cc's of junk. So if you dilute it that way, and a disc is very small, you're only going to be able to get a cc or so in a disc. So as you can see, you've just delivered a very tiny percentage because you've only used one of those 10 cc's that you got in your machine. You've thrown the other 9 away or used them elsewhere. So as far as treating the disc, you had a low dose or an LD BMC type treatment. Now, if you can concentrate all of that 60 into 1.5 cc's or 1 cc, you've then got a much higher dose, more consistent with what the Patine study showed, that you had to go higher on the dose in order to get the effect. So that's what I mean by HDBMC. When we inject a disc, we'll take 90 cc's and put it all in 1 or 1.5 cc's and inject that entire stem cell content of 90 cc's of bone marrow into that 1 or 1.5 cc disc. Let's see here, Dinesh. And now I'm on to Zhao again. And you also use into the multifidus in the same procedure. Yeah, Zhao, we definitely inject the multifidus quite a bit, and we'll do that in the same procedure. Again, we have to get away in regenerative medicine from what we were taught in interventional spine. What we were taught in interventional spine is isolate the pain generator, block it, and then nuke it, right, with RF or something like that. It's the opposite concept in regenerative medicine. While that may be important, where you're struggling to find a pain generator and struggling to find where to treat, regenerative medicine is more a pain structural approach. So you want to make sure that if you're going after, let's say, the L5S1 foramen and doing an L5S1 transforaminal epidural with biologics, that you want to stabilize that level by treating the ligaments and treating the multifidus muscles. Again, pain structural. So a find the magic pain generator approach might only apply if you're struggling to find where that pain generator is, but if you know the pain is coming from the L5S1 level, you need to treat that L5S1 level and all aspects of what might be wrong with it. ZBIG, what technique do you use for epidural injection, interforaminal, interlaminar? Do you use catheter Rex, for example? Yeah, ZBIG, we use transforaminal, what's called here transforaminal, it may be in Europe called intraforaminal, but that's what we use here at this clinic almost exclusively. We will do some caudals. Every once in a while, we'll do an interlaminar where we're trying to get to a specific area, but we tend to use transforaminals. We don't use catheters in general, other than if we're trying to break up some perineural fibrosis or something like that. John, your thoughts on a subchondral versus intradiscal injection of BMC, subchondral in this context. Do you mean, John, injection into intervertebral? I would start personally with intradiscal injection, but listen, you could make an argument in a patient with modic changes that you may need to inject intradiscal. Now, we've seen modic changes go away or change after intradiscal culture expanded mesenchymal stem cell injections. But in some of these bone marrow concentrate injections, it may require going into the vertebra. And I don't know that anyone has proven that one way or the other, but I think it's important to keep in the back of our heads and conceptualize for sure. Right now, we just go intradiscal. In this context, now we do a lot of bone work in knees and hips and shoulders, but in discs yet we have not gone intravertebral or into the bone at this early juncture, but it may be what we end up doing. Alariza, does pros of the intradiscal HDPRP outweigh its cons on the better way to get intradiscal done with HDBMC? Does a herniated disc also respond to intradiscal injections, at least? Yeah, so Alariza, as far as herniated discs are concerned, the good news about a herniated disc is that the body will generally tend to clear up the herniated disc material. So if it's a disc extrusion, we can normally just inject platelet lysate epidural, and we'll see quite a big difference. And if you leave it long enough, the body will generally clean it up as well. So it's either the platelet lysate is helping that, or we're just doing it for comfort and relief while the body's cleaning it up. Now, for a disc bulge, where you don't yet have the nucleus pulposus extruded out into the spinal canal, that's a little different story. So in that particular situation, we can make the patient comfortable oftentimes by injecting the epidural space, but if that doesn't work on a long-term basis, it's possible to go inside the disc, and in that case, we would tend to use culture expanded cells, not bone marrow concentrate. Now, let's walk that back to a different kind of disc. Another kind of disc would be a leaky disc, a disc that has a tear in it causing a chemical radiculitis. In that situation, bone marrow concentrate or PRP into the disc may well be the best thing for that patient, because you don't have, they usually don't respond well to epidural treatment or extradiscal treatment, and you may need to attack the problem at its source. Dinesh, for intradiscal HTBMC, are you going into the nucleus pulpus or AF, and do you have a concern for AF disruption and further tearing? Yeah, Dinesh, we have a large case series that's about to be submitted. It'll be a while before it's published, on culture expanded MSCs where we went intraannular. In about 40-some patients, we only saw one patient that we could passably say may have had a herniation from disrupting a very fragmented or annulus that was holding on by a thread by going intraannular. So we're not too concerned about intraannular disruption, although it can happen, and we certainly tell patients it can happen, in which case they may need to get a surgery. We're doing both. For BMC, we're primarily going intradiscal for culture expanded MSCs, the kind that we would use down in Grand Cayman. They're specially culture expanded to focus on cells that will survive the disc. We're going into the annulus and not too concerned about disrupting it. Are you using sentinel elastography to evaluate regeneration of the multifidus or other ligaments or tendons? What have you seen? Yeah, Zhao, it's funny, we did try to use elastography with ultrasound in order to quantify movement within the multifidus, and regrettably we weren't able to correlate it very well with MRI findings of multifidus atrophy. So we kind of abandoned that one on the multifidus side more recently. We tried it for about a year. We had a fellow working on it, and we couldn't really make it work very, very well. Now, it could be that we need to use a different type of elastography, where we're using the older stuff on the GES7 in a research package, but it could be that other types of elastography may work. John, below the end plate and into the vertebral body. Yes, yeah, John. So again, it could very well be that that is absolutely necessary to treat some patients and to get them better. I don't think anyone knows at this point, and it's a reasonable thought for sure. So let's see if there are any more questions that anyone has here. I'll give that a minute or so. Okay, well, I'm going to go ahead and wrap this up here. I really appreciate your time today. We did record this, so it will be available to watch at a later date. And really appreciate you taking the time out of your busy schedules to get online with me. So have a great week, and I look forward to seeing you at the IOF conference it's probably coming up in about 5 weeks. So look forward to that. Thank you much.